and be able to have the stuff just go to the cancer. Understand the complete dosing regime. In other words, the diagnostic component versus the therapeutic component, how it all combines. And in our case, we're going to use I-131 and Indium-111. TC99MO4 negative, right? We're looking at physiology. So tell me about the physiology. How does TEC go to the stomach? Tell me about how protectate acid is made. Tell me how the kidneys extract technetium off of the vascular pool. Why does salivary glands pick it up? Why does the thyroid gland pick it up? Right? I mean, it's all broken down in those individual components. Along with that, I think another interesting aspect of the whole thing is vascular pool versus interstitial fluid, VF versus VP versus IF. All right, so when you look at those two things, remember that the TEC is only partially bound to the RBCs, and so there's kind of a relationship between the partially bound to the RBCs, the free TEC in the RBCs, and then the free TEC in the interstitial fluid. And it's because there is so much more activity, volume in the interstitial fluid, therefore there is 3 to 4 times more TEC in the interstitial fluid. And again, when I say how does the body reduce it biologically, that agent, the GI tract, the kidneys, the salivary, sweat glands, everything is biologically eliminating the agent, whether in a small portion or a significant portion. So, all that good stuff. Anomalies of nuclear medicine. This is kind of like a recap of stuff. Really, there's a lot of interesting information in it. And so when I gleaned off it, I said, what's the importance of doing quality control in a gamma camera? I mean, that's instrumentation 101. But, why do we do it? And I give you some examples of what actually can happen. Issues related to gastric emptying. What's the big problem with gastric emptying? There's no standardization, absolutely. So, you can do 4 hours, you can do it till they're 50%, you could give oatmeal, eggs, toast, bacon, cheese. No, I'm just being sarcastic. But, you can do a myriad of meals. You can do anterior, posterior. Now they're saying, 45-degree LAO? No, I don't have that in the notes, but they're saying that's even more accurate. Then there's also, why do you go 4 hours versus 2.5 hours? What's the big issue about going 4 hours, even though most of the time it seems like a waste of futility or exercising futility? You know why? What happens with our sensitivity and or specificity of that disease? In relation to what?
The amount of time you go? Because if you have somebody who isn't digesting.
Right. But okay, so somebody hits 50% in 80 minutes, normal. But you go out 2.5 hours, and you're done. So why do you go 4 hours? Any idea? Yay, nay? Because even though it appeared normal, that after they got down to 50%, their digestion slows down. Therefore, they're abnormal, but you missed it because you let them go and they had 50%. And I forgot the exact number. I think it's like 23%. It actually increases the amount of abnormalities that you can. In other words, you get all the normals you find 25% more abnormals on that population. So that's why, again, extend the time. But again, what's the problem? Yeah, no standardization. Would we say the same thing for C? EF for the GB with CCK administration? What do you think's wrong with that? Actually, there's 2 things that are wrong with that. They're the way I evaluate it. But go ahead. Anybody want to comment on that? Or how fast you administer it. So what do we know? The longer we administer the cholecystokinin or its derivative thereof, what happens to the mean ejection fraction? It increases, absolutely. So if it increases, why are we always saying that 30 to 35% is the abnormal range? It doesn't make sense. I mean, in my opinion.
So the longer the injection of the CCK.
Right. The longer you infuse it, double check the numbers. And if I am incorrect in that statement, the statement is that based on infusion rate, the mean normal ejection fraction changes no matter what.
So
Overall, I think it does generally increase, which tells me then why are we settling as 30% abnormal, 30-35% equivocal for abnormal.
Some doctor decided that's how we were going to do it.
And actually, the way they decided it, it was based on the 3-minute ejection fraction. That's where we get all our. So, does that sound scientifically sound? No, it does not, in my opinion.
Also, there's no standards.
And then we go back to number B compared to C. They're both exactly the same, and you're absolutely right. There are no standards.
Here's a Joe, she does the half a cc every 30 seconds, whereas Andy, he does 1 ml.
In the same clinic?
Yeah.
You've
1 ml.
got to be kidding me.
A minute. So,
That's insane.
But I follow with Joe because you know how if you do 0.5 every what was it?
I'm not saying either one is right or wrong, but okay. So you have the same procedure with 2 totally different protocols. No. No.
But on the protocol book, it's the Joe's way.
Okay, it's Joe's way.
So
then
it's
everybody
just
ought to
saying
be
it's a
doing it Joe's way.
But they don't.
Because the numbers are different. You know they're different. I've showed you. Wow. At least when you're, at least if you're doing the same, think about it from another standpoint. Even though I question this on whether or not how accurate it all is, if you're always doing it the same way, and you send the patient out to surgery because they need to have a cholecystectomy, gallbladder's removed, yeah, it was a pussy, nasty gallbladder, good job, good call, nuclear. Right? So you get that correlation. But, if you're doing totally different protocols, wow. I don't know. Whatever. I don't work there.
Yeah, exactly.
If I worked there, Andy would not be happy with me. Dude, what's in the procedure manual? But anyway. Spot versus whole body? Okay. What are issues with spot versus whole body? What's the big thing about a spot versus whole body scan? So you think you see something, you're not sure on a whole body, so you do a spot view to see if it's really there. But in essence, what's really the problem when we compare spot to whole body images? Not enough counts. Not enough ability to really see what's going on. Too much noise. Absolutely. Problems with contrast enhancement. Remember that one? Which again, that's actually a 317 lecture. But how you adjust the contrast, you can either mask a hot defect by bringing down the high end of your contrast, or you can mask a cold defect by bringing up the low end. All right? Either way, so problem. Bayes' theorem. Remember what that was? Bayes' theorem? Hmm? Something like that. Something like that. It's where you only want to evaluate patients that have a moderate probability of disease. Low probability patients that are diagnosed with having disease generally don't, and those that have a high probability of disease, then you don't find anything, probably really do. Which goes back to, you just said, Wayne, goes back to gallbladder ejection fraction. If you remember gallbladder ejection fraction, one of the other things that I throw out at you is there was one study where the normal standard deviation gallbladder ejection fraction crossed over to the abnormal standard deviation ejection fraction. So they overlapped. So if you did two standard deviations in both directions, they both shared the same space. Does that make sense? It may make sense, but you know, does that in a way not make sense? You know, your variation is too high. How can you, if you, because normally I would think, tell me if I'm wrong, but from what I read in the literature as a general rule, you know, if they got numbers and they're evaluating numbers, they want everything to be within roughly 2 standard deviations. To be either normal or abnormal. If you come up, if you have some kind of quantitative value. What about biology? Does that make sense?
3.
Huh?
It's normally 3 in biology.
Okay, well, in medicine I would say more likely 2. If you're doing research, that's different. But you know, if you're just going to do your regular, that's 95%, you know, of your population. But in my experience, thallium versus technetium cardiac agent with wall motion. Remember that? Does it really make a diff? Is there really a difference? Do you do wall motion with thallium versus technetium? Right, but that's not what I'm looking for. Counts. Thallium counts versus technetium counts. Less counts, right? But what they have found is that it generally is overall they both have a high level of relative comparability. The problem is that there is some, I'm trying to remember, inner observer error, and if I remember correctly, the other thing is that there is other problems with attenuation, low attenuation defects. But as a general rule, they do both work. What happens when you have too many R waves? What does it look like? Remember? What looks like what if you have too many R waves? Sinogram, monogram. Looks like movement, right? But it's really not. It's just like, it's all sliced up, but it's not movement, but it looks like it's movement. And then the role of CT in attenuation, what problems might you have? You know, there are multiple things in a CT scan that equate to attenuation that we have to think about. Poly versus monogenic beam, or radiation beam versus beam. Increased attenuation via Compton photoelectric with CT. Energy can't be the same no matter what you do. And then the concept of segmentation, of trying to segment the attenuation coefficients based on the stuff that CT is going through. So high attenuation objects are going to add or take away PET gamma rays, or photons. High attenuation, patients got metal in their mouth, and you do a PET scan, and you do CT correction for attenuation. So what's the CT scan going to tell the PET picture to do? Add or take away photons?
Take away.
Add.
One of you's right.
So high attenuation, like a metal, is going to absorb.
So if CT has high attenuation, think of it from this perspective. If CT has identified something high attenuation, and you've got radiation coming out of the area that's highly attenuated, then there's going to be less photons or more photons coming out.
Less photons.
Less photons, right. So less photons, so CT is going to tell PET to do what? To add, right? And versus air, if you got air, as a good example in the lungs, you got X gamma rays coming out, and CT is going to say, oh, that's air, so there's less attenuation, so you need to do what to the photons? Add or subtract? Subtract, right? Take away because there's less attenuation, add if there's more. And then we know from there, if you've got metal, or if you've got rings, or if you've got anything of that nature as a general rule, the CT is going to add counts. Contrast, it's going to add counts, and it's going to perhaps cause a false positive. So you have to look at the attenuated image versus the non-attenuated image, essentially. the one example, what's the one example that has higher